Welcome everyone to The Whole Itself Remains. I'm your host, Todd Caldecott, and you're listening to CJMP Co-op Radio 90.1 FM, broadcasting from the qathet region on the beautiful Sunshine Coast of British Columbia, on the traditional territory of the Common People. This show is part of a weekly live Q&A series where subscribers can join me each Wednesday to explore health, healing, and human wholeness. After the broadcast, we'll dive deeper into a 30 to 60, 90-minute Q&A where subscribers can ask me anything, clinical, personal, or philosophical, certainly anything related to health and wellness. That's the topic of this program. If you're tuning in on CJMP or watching later on YouTube and you want to join this live conversation, stay with me and I'll explain how to subscribe at the end of the show. So this is the 5th episode of The Whole Itself Remains. So we're chugging along here, putting out content to hopefully interest and satisfy you. A couple little notes just before we begin today. I wanted to mention that if you're in Toronto, I'll be speaking at the 17th Annual Holistic Nutrition Conference. This is hosted by the Canadian School of Natural Nutrition. I'm going to be delivering a lecture on dementia. From an integrative perspective, I'm going to review key etiological and pathogenic factors. I'm going to follow this with an evidence-based review of prevention and treatment, utilizing nutrition, medicinal plants, of course, and some essential supplements. And then if you're around, I'll also be available after the talk to sell you my book and do some signings. And then later on in June 27th through 30th, I'll be at the Kootenay Herb Gathering in the Slocan Valley of British Columbia. I used to live out that way. I used to live in Proctor, which is near the Slocan on the other side of Nelson. So my old stomping grounds. So I have a lot of affection for that area, and I know the local flora and fauna quite well. But I'll be there to attend the Kootenay Herb Gathering. And, it's a great lineup of teachers this year, so I'm looking forward to that. I'm looking forward to connecting with my friends and colleagues. So I'm offering 2 lectures. The first one, an integrative perspective on aging and longevity. So it's going to be a class that reviews the mechanisms of aging, including things like oxidative stress, mitochondrial dysfunction, and hormonal decline, which is the subject of today's show. And also, I'm going to be exploring some traditional rejuvenative systems such as Rasayana, used in Ayurveda, Yangshen, used in Chinese medicine, and the concept of tropho restoration, applied from a Western herbalist or physiomedical perspective. And I'm going to focus specifically on diseases associated with menopause and andropause. And then I'll also be offering more of a fun experiential class entitled Embodied Constitution and Exploration of Prakriti in Ayurveda. So this is going to be just that. We're going to be reviewing the Ayurvedic concept of constitution or Prakriti through a review of the classical theory underpinning it. So a review of the gunaha or qualities, the bhutani, which relate to the elements, and the dosha, of course, the 3 doshas. And providing practical tools, demonstrations, some self-assessment techniques that can support you as an individual, as a practitioner, as a student, in the application of this type of constitutional analysis that is very important in Ayurveda, but I want to make sure to put it into its proper context as well. Okay, so just some little notes there about some upcoming events. And today, I wanted to talk about perimenopause, or menopause and perimenopause. And this is due to a request by one listener in particular who's been asking me for some time to talk about this subject. And I thought it would be a good time to review it. And so we can just kind of jump right in. I did mention that this is something that I will be reviewing in part in the Kootenays. From a different perspective, I think, and also I'll be covering just general mechanisms of aging and what we can do to prevent that, and then also looking at the different pathologies associated with the male side of the equation, andropause. But today we're going to focus in on menopause and perimenopause. And, it's a really important subject for me to cover. I've been practicing for almost 30 years, and I would say that in that time, a good 60 to 70% of my my patients have been women. And that I would say probably at least half of them have been women that are perimenopausal or menopausal. And I owe a lot to this cohort. I really do. I'm really, really grateful to this group of people, these women that are interested in what it is that I have to offer. It seems to be part and parcel of becoming older, and particularly as a woman, I think women have a much greater capacity to understand transformation through time. Because I think one of the things that happens as a woman is you just go through the normal menstrual cycle. You go from being, quite, let's say, up in terms of how you're feeling about yourself when you're ovulating. Things are going well. Everything is aligned with, feeling attractive and fertile. And then there's the descent into that premenstrual cycle and then menses, and typically it's accompanied with this sort of hormonal crash, and then the opposite feelings. No, they don't need to be extreme. Hopefully they're not, and that's one thing that women do come to seek my support, is to help moderate those changes so that they're not so profound and difficult to transition through. But nonetheless, women do go through that change. And because women go through that change throughout their entire lives, I think women have a greater capacity to understand the nature of change and the fact that they are changing and that the world changes because their bodies are continuously changes. Whereas I think men don't really have that innate or intuitive sense of change, and therefore maybe don't have the same type of flexible thinking. And so the more flexible thinking that I think being a woman provides you, not just going through those experiences of hormonal changes, but also just by virtue of how the brain develops in utero for females as opposed to males, women have a much greater capacity for integrative thinking. And so I think women, especially when they reach a certain age, if they haven't already, are drawn to natural medicine because they understand that the only way to really address these types of changes is from some type of sustainable basis. And I think there's the natural function of wisdom begins to kick in when a woman enters into perimenopause. She understands the limitations of her own life, that it's not going to last forever. And essentially that's what menopause is. It is kind of like a death, isn't it? Where you are transitioning from your formerly fertile self to the infertile self. And how do you bridge that transition to bring significance to your life? Because obviously as a woman, your whole purpose and function isn't just to be a baby maker, right? And yet biologically, this is the impetus for so many of our behaviors and activities. And so when women go through this change, this perimenopausal change, it typically brings about a type of identity crisis and a reassessment of their basic values. So many of the formerly cherished ideas and values they had about the world or relationships come under pressure during this time. And as a result, I think many women seek out holistic solutions because they realize that there's much more to life than just, being a fertile baby maker. And that in order to come up with a sustainable way to manage that or bridge that transition, we need to think holistically that addresses concerns and health issues without pathologizing them. And I think that's a really key point here because for so many years, menopause has been viewed as a kind of pathology that needs to be treated. This is from a medical perspective. But of course it's not. If you're going to live a full life as a woman, you're going to go through menopause. It is a natural transition. But how do we support a woman through that natural transition so that she feels empowered and strong? She has all the tools that she needs at her disposal to be fortified against these changes, to ensure good longevity and good health, all the factors that we want as we get older. How do we set ourselves up to experience those benefits in a holistic way? So this is why I think many women would come to see me because innately they understand that they're going through this profound change. They're looking around them for more sustainable ways to address this change and are drawn to natural medicine because of that. So, I owe this cohort an enormous amount of gratitude. I don't think I'd actually have a profession. I wouldn't have a career if it weren't for perimenopausal women. So, thank you so much. So let's talk about the subject in a little more detail. So as I mentioned, menopause was seen as a disorder that should be treated from a medical perspective, but it is a natural transition that all women will go through. It arises because of the natural depletion and aging of the finite number of oocytes. These are eggs in waiting that are contained within the ovaries. And perimenopause is that transitional phase before menopause takes place. And this is marked by hormonal fluctuations, primarily a decline in both estrogen and progesterone. It usually begins in a woman's 40s, but it can start as late as the 30s. As early as the 30s, as early as the late 30s, and as late as the mid 50s, and typically lasts somewhere between 4 to 10 years. When we use the term menopause specifically, we define it as no menstrual bleeding for at least 1 year. And this is typically commensurate with a functional decrease in hormone production by the ovaries. And we can confirm this by measuring hormone levels in the blood, urine, or saliva. Now, there's some interesting cultural and racial differences, and of course, individual differences. So nobody experiences any condition exactly the same. So we always need to account for those individual differences. So apart from those individual differences, there's also a difference in symptom severity and duration that can vary by race and ethnicity. So for example, African American and Hispanic women may experience more severe symptoms. This has been reported in the literature, while Asian women tend to report fewer symptoms. Now, I don't think that this has anything to do with race per se, but different cultural factors such as environment and especially diet. And I would say overall, if we're looking at the nature of diets across the world, folks that are of Asian descent tend to eat a little more healthy. I think Chinese cuisine and Asian cuisine across the board is definitely one of the healthiest cuisines on earth, particularly if it's, fresh food. I'm not talking about, say, like Canadian Chinese food, sweet and sour pork and, deep fried wontons, but like real authentic homemade Asian food. It's emphasis on minimal cooking, brightly colored vegetables prepared in a way that enhances digestibility and assimilation. Lots of soupy, meaty dishes as opposed to like fried or deep fried foods. And because there's this long continuity of culture, these culinary practices have been maintained across generations, where that can't said to be the same for folks of African American or Hispanic descent, where there's been more changes, particularly in America. And I think this is also impacting Asian populations across the board. So this is kind of a lagging indicator, obviously, because I think now when you look at people's typical diet, if they're acculturated Americans or Canadians eating typical American or Canadian food, I imagine that they're going to have the same type of risk factors and may experience the same kind of spectrum of symptoms and symptom severity because of the similarity in what they're eating. And we'll talk a little bit about that today, about what we eat and how it can affect things like hormonal regulation and symptom severity. So if you look across the world, it's pretty common, pretty similar in terms of like the age of last period. In the US, it's around 51 years. In Greece, it's said to be 49 years. In Egypt, 47 years. In India, 46 years. And some of this reflects like longevity, because the lower degree of longevity, then it's more likely that on an average basis that women are going to go into menopause earlier if the longevity on average is less. Now, typically about 2% of women experience menopause before the age of 40, and about 5% of women experience menopause between the age of 40 and 45. I've certainly worked with women that are in their late 30s and early 40s that are in a new relationship, for example, and they want to have a baby. I would say my track record's pretty good. If I would just hazard a guess, I would say it's probably about 80%. So it is possible to recover a significant degree of fertility, even in women that are in their early 40s, but typically by about mid-40s, it becomes much more difficult. Unfortunately, that if the woman hasn't had a child by then, that she might have missed the window of opportunity there. There are a lot of conditions that can accelerate menopause, so that's something that's important to be aware of. So, for example, premature ovarian insufficiency. This is when ovaries cease production before the age of 40. It affects, as I mentioned, about 1 to 2% of women. The causes are typically, in my experience, autoimmune, but they can be genetic or unknown. Even among those that are considered to be unknown or idiopathic, I think autoimmune is a significant component. Autoimmune disease is very poorly defined. We have really insufficient tools to properly understand autoimmunity. If autoimmunity is just like, say, looking for elevated levels of rheumatoid factor or CRP or wherever it is, then maybe it's a very more rare diagnostic category. But I think autoimmunity is actually more broad, and many people will experience kind of a borderline autoimmunity in their lives that give rise to kind of more muted symptoms that can affect things like fertility as well as things like joint pain without being thrown into a full-blown autoimmune condition. And I think that is responsible for causing a lot of infertility that I see in women. And that is usually typically addressed by something like diet. Of course, also a hysterectomy will cause menopause. It could be with or without a bilateral oophorectomy, so removal of the ovaries as well. Endometrial ablation or uterine artery embolization. These are both treatments that are used for heavy menstrual bleeding, typically associated with fibroids. There's some other additional risk factors for early menopause: undiagnosed and untreated celiac disease, cigarette smoking. If someone is carrying a lot of weight, a lot of truncal abdominal obesity, or we could say has a higher body mass index, and then just chronic illness. All of these things can add up to making a woman infertile and accelerating the phenomena of menopause. So the hormonal changes during menopause are classified by changes in bleeding patterns and specifically different hormone levels. Now, women of reproductive age, the ovaries produce estradiol, progesterone, and testosterone, and it's done so in a cyclical pattern under the control of follicle-stimulating hormone and luteinizing hormone. Both of these are produced by the pituitary gland. And as a woman approaches menopause, there's a gradual depletion of oocytes, and this results in a positive feedback loop, increasing circulating FSH and LH levels because there's fewer oocytes and follicles responding to these hormones. And as a result, the brain will pump out more and more FSH and LH to stimulate those oocytes and follicles. That is a positive feedback mechanism. Now, typically, as a woman is going through perimenopause, the estradiol levels remain relatively unchanged and can even increase compared to fertile women. That's why it's important to make sure when you are getting assessed for perimenopause that you get a full hormone panel. I'm going to talk about testing as well because there are some challenges with hormone testing when it comes to menopause, but it is not uncommon to see estrogen levels increase. And just overall, the pattern typically is usually one of fluctuation. But one of the key components that's happening is that you get ovulatory failure and therefore a decrease in progesterone levels. So the menstrual cycle is proceeding after a woman stops bleeding, then the endometrial lining is being regenerated. That is done so under the influence of estrogen. It takes you to mid-cycle. You get that surge of LH from the pituitary gland, and that causes the release of oocytes and then progesterone from the ovaries. But as a woman reaches menopause, you will experience ovulatory failure. And so the progesterone levels don't spike. You don't get that spike, that increase in progesterone mid-cycle. And that's significant because it's progesterone typically around mid-cycle during which a woman experiences feelings of like a good mood. I mean, it's associated also with a secondary bump in dopamine. And that makes sense biologically, right? If a woman is fertile and her body's like saying, okay, it's time to get pregnant, she's going to feel good, she's going to feel attractive, she's going to feel sociable. And these are all things that dopamine does under the influence of this surge of progesterone. So when there is this ovulatory failure and no increase in progesterone, then it's going to be accompanied typically by a lack of those types of mid-cycle mood improvements. And that's one of the key things that we'll often see. Not just the changes we'll see like in the cervical mucus, that sort of egg white discharge that women get mid-cycle, but the commensurate increase in mood, libido, etc., those things also fail to manifest. And that's usually a clue that there's some degree of ovulatory failure or incomplete ovulation. And that can happen at any time during a woman's reproductive life, but becomes more frequent as a woman begins to move towards menopause. So less frequent ovulation overall is happening during perimenopause. So fewer cycles. And so the corpus luteum that forms when the egg is discharged from the ovaries and produces progesterone, it's not being formed properly. And the thing about this is that this low progesterone contributes to a state of relative estrogen excess. So here, estrogen levels remain high, though they're fluctuating. They remain higher relative to progesterone. And the result is that the menstrual cycles during perimenopause often become shorter or more irregular. This is one of the general traits of a reproductive cycle in women, that if we're seeing consistently short cycles, say like 21-day cycles, and we're not getting that mid-cycle bump that you would normally get around, say, day 14, then probably there's ovulatory failure and elevated levels of estrogen and low levels of progesterone. It's predictable. And if that's happening in a woman of reproductive age, then we're looking to properly stimulate the ovaries to produce progesterone so we can lengthen that cycle and ensure proper fertile cycle, which is going to be around 28 days. So not only do the cycles become shorter and or more irregular under the influence of a progesterone deficiency and a relative estrogen excess, also levels of total and free testosterone, as well as DHEA, sulfate, and androstenedione, they also typically decline more or less steadily with age. And what's important to note about those things is that they do contribute secondarily to things like libido. Having low testosterone as a woman could affect things like libido, and that's a very common trait. Obviously, as women go through perimenopause and menopause, is that they may have less interest in sexual activity. I don't think it's necessarily just hormonal. I think it's commensurate with just the broader effects of these changes and how a woman begins to view herself within the context of society and her life, right? So transitioning from that, proverbial biological baby making machine to, the grandma phase, you could say the crone phase or the witch phase. I don't want to be derogatory. Many women claim that title and should if they feel comfortable with it. But where you begin to reassess your life and realize that you're more than just someone's companion, you're more than just a baby making machine or a mom or whatever it is, that you have an independent existence separate from all of those things. And that's part of this wisdom change that happens as women go through this transition. Right? And that's commensurate with typically this decrease in testosterone. Like a lot of women around perimenopause, even if they're in a long-term relationship, they may undertake a very frank reassessment of that relationship and wonder, why the heck am I with this person? Like, I'm not getting anything out of it. Like, I'm having to take care of them, I'm folding their laundry or whatever, making meals for them, taking care of them. Before it was some kind of feedback mechanism that matched their biological urges, but now as that diminishes, then a reassessment is taking place. And it's like, well, what's the point of this guy anyway? Like, he's just more work than he's worth if he's a guy. Okay. So after menopause, the estrogen levels actually continue to be produced mostly by aromatase and fatty tissues. So this is what's really important as a woman as you go through menopause, is you want to make sure that you're carrying a relatively high amount of fat, at least not being very skinny, but it's where the fat is distributed. So, it's very common as women go through perimenopause to start accumulating fat. If you're accumulating fat on your thighs and your butt, your breasts, that's fine, right? Those are going to serve as storage sites for the synthesis of estrogen. And your body needs estrogen. Your bones need estrogen. So in women, the function of osteoblasts, the cells that lay down new bone, their function is stimulated by estrogen. So a decline in estrogen means that those osteoblasts are not being properly stimulated and cannot counterbalance the activity of the osteoclasts, which resorb bone. So you have this yin-yang balance between osteoblasts laying down new bone, osteoclast that reabsorbs old bone. And if you lose estrogen, then there's this net increase in osteoclast activity, hence an increased risk in osteopenia or osteoporosis. So that becomes really important. So carrying a little bit of extra fat around your butt, your thighs, breasts, etc., this serves as an estrogen storage site from the androgens produced by your adrenals. Now, it's different if you've got fat around your belly. That's from insulin resistance or hypercortisolemia. That's a different thing. That's a pathological thing. So you want to maintain that healthy waist to hip ratio. We talked about that before, where a woman's waist should be no more than 80% that of her hip circumference. And you maintain that, even if your body changes, you gain more fat. But if you maintain that body proportion, then you typically are going to move through menopause well and are able to avoid the most common diseases. I mean, you will die of something eventually, but cardiovascular disease, diabetes, cancer, diabetes, etc. This is going to be dramatically reduced if you're able to maintain those healthy waist to hip ratios. So you do keep producing estrogen. It just doesn't come from your ovaries after menopause. So, as I mentioned, estrogen and progesterone levels can fluctuate a lot in perimenopause, and it makes it very difficult to capture a consistent picture of what's happening, especially if you just employ a single test. Even in a single day, hormone levels can vary, and that's true not just of these sex steroid hormones, but also things like thyroid function. So you never want to make a diagnosis or an assessment based on one blood test, especially a blood test, because it's like a little tiny snapshot of what's happening. And, just like you wouldn't make any assumption about anything in your life if you only had a little tiny snapshot about something, you'd need context. And ideally, when you're looking at a test like this, you want to be able to graph it over time so you can see what the trend line is. So there's a few different types of blood tests. The most common one that's used typically in medicine are serum blood tests. This is a measurement of the hormone levels in the blood. Unfortunately, they often do not accurately reflect tissue levels. So not only they are a little tiny snapshot of what's happening at that particular moment in time, but they're not telling you what's actually happening on a tissue level. There's also differences in hormone form. Some hormones are bound to proteins, for example, like sex hormone binding globulin, and therefore inactive, while there's other hormones that are free and biologically active. Now, blood tests typically measure total hormone levels, including both bound and unbound forms. So if you're just using that very simple test, then it could be misleading because you're not getting a sense of the actual functional hormone levels. And you're counting those bound hormones that are basically inert. They're not having any biological activity. So you want to go with the free hormone tests. These measure only the unbound portion of the hormone that's biologically active and then can enter the cells to exert whatever effect those hormones exert. Could be, free estradiol-2 or free progesterone, etc. And these are the tests that are commonly used in standard medical practice. But as I mentioned, they suffer from the fact that they're just little snapshots. Another option are urine tests. These measure the hormone metabolites. So they're not actually measuring the hormone levels themselves, but after the hormones have been utilized, metabolized, and then discharged into the urine, we can then measure those metabolites and then from there construct a picture of what hormone levels are like. It's very useful because it's not just a snapshot. When you're measuring urine metabolites, you're measuring something that reflects a longer period of time, like I say, a 24-hour period. It's also non-invasive, a urine test, whereas blood test requires a blood draw. It's not direct, obviously, in terms of measuring hormone levels, so it does suffer from the fact that it is kind of an inferential method of assessment. And one common method that people are using, that I use as well, I'll look at these tests, are Dutch tests. Dutch urine tests for measuring hormone levels. And I think they're very helpful. If I'm looking at, say, measuring hormone levels in a perimenopausal woman, then we'll say measure hormone levels in the early stage of the follicular cycle. So say in the first part of the menstrual cycle, maybe right in the middle before ovulation, and then in the mid to late part of the luteal phase, the second part of the menstrual cycle. So we're measuring urine hormone levels, urine metabolites at either end of the menstrual cycle, not during menses and not during ovulation. And then the other technique in terms of assessment are salivary tests. These measure the free unbound, i.e. biologically active hormones. They're very useful in the sense that they can track fluctuations throughout the day. So if you want, you can have the patient undertake these tests twice a day and then at any given point during the menstrual cycle. They're also non-invasive. They're very effective in particular for measuring topical hormone therapy. So measuring something like progesterone cream. Now, there's a lot of controversy about progesterone cream. Typically, doctors do not recommend progesterone cream. They suggest that it's not that effective, especially when you look at how much hormone is actually being utilized per dose. It's not very much, say like 20 milligrams of progesterone in a topical administration of progesterone cream. Whereas if you're taking like an oral micronized form, it might be 200 milligrams, 300 milligrams, 400 milligrams, much, much higher. Doctors, their bias is towards stronger is better. The problem is that very little of the oral form of that hormone that you ingest actually gets to the tissues. Most of it gets taken up and detoxified by the liver, adding to the burden of the liver. It gives the liver more work to do. And this can be counterproductive if the liver is already struggling. And that's something that we typically see in women. I mean, I think all of us, generally speaking, livers are exposed to so many xenobiotic compounds. And of course, psychosocial stress also affects the liver. Usually people's livers are struggling or stressed out. And certainly the case as you're transitioning through something like perimenopause. So it's not equivalent to give a woman a oral micronized form of progesterone and then the topical form, because when you apply the topical form, that goes directly into the tissues. And there is research behind this showing that it is much more effective and a much more direct way to boost tissue levels of hormones like progesterone using a transdermal cream as opposed to taking an oral form. So, I don't often use progesterone cream. I'll try using medicinal plants first, but if the medicinal plants aren't working and diet, supplements, etc., I think it's a more sustainable thing. But if it's not helpful, if we need more, then I'll usually move to something like a progesterone cream. I don't think I've had a case where when we've done that it hasn't been helpful or effective. But in order to properly measure the efficacy of these topical progesterone creams, you can't rely on a serum blood test because the topical progesterone creams, they don't measurably impact serum levels of progesterone. So to a doctor, it's going to look like it doesn't do anything. And yet, a woman subjectively, she'll feel better, she'll be getting sleep, the hot flashes will resolve, all the typical perimenopausal symptoms begin to get better. And yet the serum levels aren't showing that. But when we use a salivary test, we can see the difference. So if you're going to use like a progesterone cream, then you want to make sure that you're using the right assessment method, and that is going to be a salivary test. So let's talk about a few different conditions of perimenopause. There's a whole bunch. I'm not going to be able to get through all of them, but let's cover some of the major ones. There are some conditions like, say, cardiovascular disease that are associated with perimenopause and menopause. But these also apply to men as well, right? So it's kind of a general pathology of aging that certainly relates to hormonal decline, as well as other things like inflammation and oxidative stress and damage to telomeres, etc., etc. So I'm not going to talk about those things because they apply generally to anyone as they age. I'm going to talk about some specific issues that relate to perimenopause. And so the first one, the most obvious one to talk about, the one that women mostly complain about as they go through this transition, are hot flashes and night sweats. So if you don't know what those are, if you've never experienced them, if you're a husband, a boyfriend, a fella that's hanging out listening to this podcast and wondering, what their mom, their partner, their wife, etc. is going through. This is a very sudden and intense feeling of heat. It's usually accompanied by sweating, palpitations, flushing. Unfortunately, it often occurs at night, and so it affects sleep. Now, there's a few different explanations as to why this happens. The conventional explanation is that declining estrogen levels affect the hypothalamus in the brain, and it makes it more sensitive to small changes in body temperature, and this triggers a vasodilatory response and sweating, causing the hot flashes and night sweats. The lower estrogen levels also associated with an increase in sympathetic nervous activity. So low estrogen levels drive that sympathetic fight or flight response, and that in turn also leads to vasodilation. And that's why also not just the sweating, but also the palpitations, maybe a feeling of anxiety, can also be associated with these events. But I think one of the key things that's happening, and it's not really discussed, is that the hot flashes serve a biological purpose to induce a thermogenic mechanism to promote the synthesis and release of estrogen from fatty tissues. And this is an interesting thing, an observation that I've made over the years, is that women that are going through perimenopause that tend to carry a little more weight, not truncal abdominal weight, but have the weight in their butt and their thighs, and they're not worrying about it, right? Because it's just a natural transition. They tend to move through menopause or perimenopause more easily because they've got all these storage sites or synthesis sites for estrogen. And what this hot flash is doing, I think, it's stimulating a thermogenic mechanism to release estrogen from fatty tissue. So it's just a biological feedback mechanism that's kicking in. And it can be mostly subtle and limited in women that have enough fatty tissue. But in women that don't have much fat, maybe they're just naturally skinny, or maybe they've just been concerned about, aesthetics and working out hard and, eating in such a fashion that they aren't able to, generate much fatty tissue, adipose tissue, they become more susceptible to hot flashes because of that deficiency. And it's a feedback response. The body's like, we need to release estrogen, stimulate the fatty tissue. Not enough estrogen gets released, and so it just feeds back to the brain to heat that up more, to stimulate those thermogenic mechanisms further. And it just kind of creates this dysfunctional feedback loop. So that's a really important thing to take into consideration. So let's think about some holistic interventions to address this. So this is typically arising because of declining estrogen levels. So even though estrogen levels are fluctuating, they're going up, they're going down, they can even be high relative to progesterone, they're still typically lower as opposed to reproductive age. So we want to benefit or support estrogen levels And as I mentioned, making sure that you have healthy fat composition, adipose tissue in your body is one key preventative factor. But you can also consume phytoestrogens or plant-based estrogens. So these are legumes, sprouts, things like flaxseed. They can be very helpful to augment your body's own estrogen and can even help prevent exposure to some of the more deleterious xenoestrogens that we're exposed to in the environment. I typically don't recommend a high phytoestrogen diet for women of reproductive age because they're already overexposed to estrogen. Number one, because of fluctuating menstrual cycles, and number two, because of the influence of xenobiotic estrogens in the environment from solvents and fuels and other chemicals. So you don't want to add to that. But as a woman goes through menopause, it might make sense to use these phytoestrogens to gently boost or support her innate estrogen status. And so you can use legumes, sprouts, flaxseed. I also like using different medicinal plants. Number one favorite medicinal plant to address this issue is shatavari. This is an Indian herb. Botanical name is Asparagus racemosa. It's also known as wild asparagus, and we use the root. The name shatavari literally means, shat means 100, avari means underneath. So when you pull up this plant, you've got this fascicle of roots. And the roots underneath avari are also described as being husbands. So one way to translate the term shatavari is 100 husbands. And that's also to denote the capacity of this plant to enhance sexual function and to boost fertility, specifically estrogen. I think it's quite estrogenic. So it's a cooling, nourishing, moistening medicinal plant. Energetically, it meets all the qualities that women need as they go through menopause. It has this natural ability to gently boost and support estrogen levels and can help address things like declining libido and also the secondary effects, addressing all the deficiencies of estrogen that lead to things like osteopenia or osteoporosis, hair loss, change in skin texture, muscle loss, etc., sarcopenia. So shatavari is really important. I typically will use it along with plants like peony. In Chinese medicine, it is bai shao. Peony, chasteberry is another one. A lot of people use chasteberry. It's a great herb, but it's a very heating, drying herb. And one mistake you can make with chasteberry is to use it by itself. It should always be used in formulation with these more cooling, moistening, nourishing medicinal plants. So I'll put it in a formula with peony for women of reproductive age to balance their menstrual cycle, given from ovulation mid-cycle until they ovulate, until they menstruate, and give it to women going through perimenopause along with the shatavari. Other herbs, dangui is also very good. It's very good for nourishing the blood, like the shatavari. If there's any issues around anemia, it's also very good for circulation and things like coldness, which, let's face it, most women seem to have that issue, struggling with circulation and feeling cold all the time. Dangui can be very helpful with that, and you can combine it with herbs such as prickly ash or ginger to augment that effect. American ginseng is another lovely plant for women going through this transition. It's another yin nourishing herb in Chinese medicine. That, of course, is the quality in Chinese medicine that women lose as they go through perimenopause, this yin quality. So all these herbs, shatavari, peony, dangui, American ginseng, they help to bring back that yin quality, that juicy quality that women are diminished in as they're going through this perimenopausal phase. Then other herbs could consider things like black cohosh. It's also another heating and drying herb like the chasteberry. So once again, it needs to be properly formulated. Red clover is another good source of phytoestrogens. Licorice is very helpful to support adrenal function. And the adrenals are responsible for pumping out androgens, which your fatty tissues are using to synthesize estrogen. So supporting the adrenals is very important. And then probably my number one herb to address just the hot flashes themselves after dealing with all these background issues is just regular garden sage. Just taking garden sage throughout the day or maybe a couple hours before a woman goes to sleep at night can be very helpful to tame those hot flashes. In most cases, when we've applied it, the hot flashes are essentially gone or so minimal as to really not causing any kind of problem or disturbance. In addition, I typically recommend some nutrients like vitamin B complex, a little bit of vitamin E, something like evening primrose oil, and or like an omega-3 fatty acid. I'm a big advocate of making sure you get those things in your diet, right? That's the key thing. And avoiding all those vegetable seed oils that are high in N6 fatty acids that tend to promote inflammation. With inflammation, you're going to be thinking more hot flashes, so we want to reduce that. And so avoiding those seed oils, I think all of us should be avoiding those seed oils, and that's like canola, sunflower, safflower, cottonseed, etc. Just avoid those. And then, supplementing for EPO or fish oil, etc. It becomes less necessary, but still, maybe some targeted supplementation for a time might be helpful. And then from a lifestyle perspective, to avoid triggers, caffeine can be a trigger, alcohol, spicy foods, those things just kind of make sense to avoid. If you've got hot flashes, stay away from the things that are very heating in nature, and that'll help to resolve it. Let's talk about something associated with that. We talked about hot flashes and how it can affect sleep. So sleep it can be affected by hot flashes, but also just independently. This seems to be a very common experience for perimenopausal women, is that their sleep suddenly becomes disturbed. And it's not just women. I think as all of us, men too, as we get older, sleep becomes harder. And we can explain this from the perspective of Ayurveda because of the shift in the balance of the different doshas. In Ayurveda, these three doshas, Vata, Pitta, Kapha. So Kapha is associated with heaviness and inertia, Pitta with heat and dynamism, and Vata with coldness, dryness, and aging. And the thing is, we all become more Vata as we get older, but we all start off as Kapha. Little babies, for example, are just the perfect representatives of this kapha quality. They're heavy, they're gooey, and they have all these kind of like congesting, squishy properties. That's what we like in a little baby with their fat little cheeks, mucus pouring out of their saliva, pouring out of their face, But we lose that quality as we get older. And you think about sleep, like we always say, oh, fall asleep. It's like falling into this quality of heaviness. Sleep it's like that, isn't it? You fall into this deep, heavy, hopefully sweet state of mind that allows you just to completely open and relax, right? So that's a quality of juiciness, of kapha, and as we get older, that gets gradually stripped away and we become progressively more vata, drier and colder. So we all experience that typically as we get older, this encroaching influence of vata, and that will influence sleep. Specifically in women, we can associate that with a decline in ovarian hormone production, a decline in progesterone in particular, but also estrogen as well. So it's typically relating to a difficulty falling asleep or staying asleep. As I said, it could be due to night sweats or from something like anxiety. And these hormonal fluctuations really play havoc with the brain. They affect neurotransmitter function, the synthesis and activity of neurotransmitters like serotonin and GABA, and this ends up disrupting sleep cycles. And as I said, the hot flashes just further contribute to this dynamic. Fortunately, there's a number of things that we can do. Number one, realize that it is natural for it to happen. And so making sure that you're just really applying the principles of sleep hygiene become important. Not to hyper focus or worry about them too much, but to make sure that you're getting to bed at a good time every night, let's say 10 o'clock at night, making sure that you're not exposing yourself to blue light or other forms of digital stimulation at night, that you're able to block out the light as much as possible, keeping your room probably a little on the cooler side, even if you're loading on the blankets. Weighted blankets can also be very helpful for people to help them feel, calm and relaxed and grounded. That can all be helpful. So basic rules of sleep hygiene and understanding that this transition is normal and natural. We will all have our sleep disturbed to some degree as we get older, and not to freak out or worry about it too much. But we do have to employ some kind of compensatory mechanism. And in India, traditionally, when people reach this age, mid-age, like around their 50s, you enter into a different phase of life. You leave off the grahasta life, which is the life of the householder. You shift more towards becoming the sannyasin, which is the pursuit of more spiritually ideas or activities or lifestyles. So, practicing meditation. I mean, meditation can be a fantastic way to get some of that restorative benefit of sleep without actually sleeping. So practicing yoga nidra at night, or meditating, or even if you can't sleep, just to get up and maybe read a book for a little while, do some calm activity in the kitchen, maybe sweep the kitchen floor, until you feel sleepy again, and then, half an hour later, go back to bed, and probably you'll sleep just fine. So I'm doing this class in a few weeks talking about dementia. Of course, sleep is really important here, but I want to make sure that you don't become overly anxious about sleep. You will sleep at some point, even if you are struggling or suffering from insomnia. There's an excellent book I would recommend to all of you that are suffering. It's called The Effortless Sleep Method. And it's really just a book talking about the psychology of sleeplessness and insomnia, and then just how to practice the rules of good sleep hygiene. But it's really important to set the proper foundation for good sleep. Otherwise, we can use medicinal plants. I wouldn't rely on them all the time. If you're having to rely on medicinal plants all the time to help you sleep, then there's probably some other underlying issue. Maybe it's a psychological problem. Maybe it is a sleep hygiene issue that needs to be addressed. But there are herbs, for example, you can take during the day that help to calm and balance your mind, just like meditation. And that would be like reishi mushroom is very good for that. Skullcap is very good. Chamomile is very good. We have these unfair expectations about sleep, that if we have kind of this frenetic day, we're busy doing all these different things, lots of emotional upheaval, that somehow, just because we're going to bed, that all that just dissipates and we can just sleep. And that's just not the case. So when people are struggling with insomnia, I always ask them to think about how do they start their day. I remember having one patient many years ago. She started her day getting up early in the morning, pouring a big pot of coffee, and watching the stock market. And she wondered why she was having trouble sleeping at night. Because she just started her day off in a very stressful way. I guess depending on the market, it could be more or less stressful. I mean, imagine right now it's probably very stressful to do that. So don't do that. Not a good idea. So those different medicinal plants I mentioned taken throughout the day can be helpful. Like taking a medicinal plant just before you go to bed and expecting it to work is expecting a bit too much. Only if you have very mild insomnia will that typically be effective. But if you have intractable insomnia or you're going through an insomnia pattern, just taking those herbs before you go to bed is probably not going to do much. You can still try, like the chamomile, valerian, passion flower. You need something stronger. Kava can be very helpful. CBD or CBD cannabis can be helpful as well. If there's chronic pain, then that needs to be addressed. If that's what's keeping you awake, then that's a separate issue. In terms of different supplements and nutrients, things like magnesium, melatonin, it can be helpful. You got to be careful with the melatonin, though. I think people probably take too much. A lot of research is suggesting that we need less as opposed to more. So start off anyway at a dose of 0.3 milligrams as opposed to the 3 milligrams that's typicely prescribed. So titrate the dose down first and see if that works, and only go up if it's not working. 5-HTP, which is the precursor to serotonin, can be helpful. Works for some people, it doesn't work for other people. L-theanine, GABA, those can be helpful. Magnesium to ease muscle spasm can also be helpful. And then, in terms of lifestyle, as I mentioned, things like mindfulness, meditation, yoga nidra can be helpful, just general relaxation techniques. But one of the things about sleep is that it is regulated by neurotransmitters such as serotonin. So, we have these two phenomena of sleep. You have the early stage sleep, which is REM stage sleep, which is that stage of sleep when you're lying there and you're not quite even sure if you're asleep yet. It's like you've got one foot in the awake world and one foot in the sleep world. And we usually rest in that state for about 10 to 20 minutes before we then drop down into a deep sleep. So in order for us to get into REM state, our brain levels of serotonin need to be very low. and then we stay at that REM state. That's what induces the REM state. That's when we feel tired at night, we're sleepy, or we're starting to fall asleep while we're watching a movie or something. Serotonin levels are low. We go to bed, and then the REM state kicks in, and then there's this secondary bump of serotonin that then drives us into deep sleep. So it's kind of this almost like a paradoxical brain state where initially we need low serotonin to fall asleep, and then to drive down into deep sleep we need the secondary bump of serotonin. Now we get that secondary bump of serotonin if only serotonin during the day was properly regulated. And serotonin is released according to circadian patterns and rhythms. So the plant form of serotonin is a hormone called auxin, and it regulates the growth and development of a plant in response to sunlight. You know how sunflowers track the movement of the sun across the sky? That is driven by auxin. So, we're basically just mobile plants. It's really no different. So it's the same thing. We need to get that sun or daylight exposure early in the day and experience those increasing levels of light. This boosts our serotonin levels, which typically peak during midday. It's augmented through exercise and physical activity. It's typically under the influence of these rising serotonin levels. We feel like we want to do stuff and move our bodies and get stuff done. And then as they peak midday, they begin to drop. And as we head towards the end of the day, serotonin levels get progressively lower and lower. We feel tired, sleepy, until finally it's time to go to bed. REM stage kicks in, and then we get that secondary bump of serotonin that drives us into deep sleep. But we're not going to get that secondary bump of serotonin if we didn't get the first bump earlier through exposing ourselves to light and physical activity. So that becomes really important. So this is a really important thing to address when looking at these sleep issues. I will say, at least from a therapeutic perspective, a lot of the issues relating to sleep in perimenopausal women are this relative progesterone deficiency. And so we'll address that by using medicinal plants like Vitex, that's chasteberry, peony, verbena, and then use them in combination with herbs like shatavari. They usually are very helpful in combination with those relaxing nervine herbs like reishi or say chamomile, etc. That can be very helpful. But then also something like progesterone cream in particular, applied before a woman goes to bed, maybe like an hour before she goes to bed, often promotes a very good restful sleep. So try the herbs first. Try the lifestyle changes, meditation, exercise, exposure to light, sleep hygiene, etc. All those things can be helpful. Then, if required, then you can think of using something like the progesterone cream. Okay, well, looking at the time, I'm going to wind things up for today. There's so much more to talk about this subject, and I think probably in the Q&A, we're going to continue the discussion. There's more I have to say on the subject. There might be some more questions. So if you want to take advantage of that opportunity, please check us out. You can join as a subscriber by going to dogwithbotanical.com/subscribe, and you can join the Q&A. Otherwise, I will post these shows, these podcasts to YouTube. The Whole Itself Remains playlist. You can check them out there. And then, of course, if you're listening on the radio, CJMP 90.1 FM in beautiful qathet, Sundays at 1 o'clock, you can hear this recording. Okay, so thanks so much for joining me today. I look forward to connecting with you next week. Until then, take care.